Dr. Lanka Liyanage, MBBS, Diploma in Chemical Pathology and MD Chemical Pathology. Lanka is a locum consultant chemical pathologist currently working at Mid Yorkshire NHS Foundation Trust, London, UK. Dr. Lanka, Dr. Lanka will talk us about her experience in renal stones today. Dear Dr. Lanka, thank you for allocating your time for us in your busy schedule. And it is a great pleasure that our trainees are joining with us and doing these lectures to us to update our new trainees' knowledge. And we are grateful for your presence here today, Lanka, and I'm sure that this will be a valuable experience for all the attendees present in this meeting today. Over to you, Lanka.
Thank you for that kind introduction. Good afternoon, everybody. Can everybody see my slide?
We can see your slides, Lanka.
Okay. Let's see whether it's, I'm not sure whether it's moving or not. Sorry, there was the issue with my slide moving. Now I think it's moving.
Lanka, if there is a problem, you can off your video. That will be better for the signals.
Okay. Can you see my side moving?
It is moving, Lanka.
Okay. There's some issue with my... Sorry for that disturbance, because there was an issue with side moving. I think now my slides are moving. So today I'm going to present on renal stones. And thank you for inviting me for this webinar. And good afternoon, everybody. So the outline of my presentation types of kidney stones and the risk factor for renal stones formation and renal stone screen and management approach. As you all know, the calcium oxalate and the calcium phosphate are the more common stones, and the calcium oxalate account for 80% and the calcium phosphate 20%. Risk factor for calcium stone include urine volume, hypercalciuria, hypoxaluria, and hypocituria. Other than that, for the calcium phosphate stones, there are some risk factors like high urine pH and the disease associated with primary hyperthyroidism and renal tubular acidosis. Uric acid stone account for only 10 to 20%, and the risk factors are low urinary pH and hypouricosuriia. And also Stewart stones, it's also called infectious stones. It's composed of magnesium, ammonium phosphate, and it associates with urea splitting organisms such as Proteus, Pseudomonas, and Klebsiella. Sometimes these patients presented with staghorn calculi as well. Cystine and the xanthine are the rare stones, and these only account for 1%. And underlying predisposition of renal stones, there are some modifiable and unmodifiable risk factors. I'm not going to discuss modifiable risk factors here because I'm going to discuss all these risk factors throughout my presentation. So here I only focus on the non-modifiable risk factors like genetic risk factors, cystinuria, primary hypoxaluria, hyperabsorptive hypocalciuria, and some structural abnormality, and infectious recurrent infection associated some pyelonephritis and urinary tract obstruction, and also gastrointestinal disease, especially inflammatory bowel disease like Crohn's ulcerative colitis, and also the patient had gastrointestinal surgery. Once patient presented to us, we do the renal stone screening. The renal stone screening consists of 5 sets of investigation. Those are patient screen, stone screen, metabolic screen, and including blood and urine. And also the final one is diet screen. Once patient presented to us, we should go through all the detail of history, asking the what are the usually we ask age, gender, and then we measure the BMI, and also we should ask detailed stone episode history and the age of first onset and the how frequent they get the attack, and the past history of medication and the current history of medical and the any associated illness, and the surgical history special to gut surgery, and the lifestyle, and the detailed dietary history, and also fluid intake and the amount of fluid, and what are the component of fluid, and what they drink, whether they drink carbonate fluid or not, those type of things we ask. And we ask about the recurrent urinary tract infection. So we should go through all this detail and find out whether patients having some risk factors or any cause which can precipitate recurrent renal stones. And stone screening is the second one. It's just like a biochemical biopsy. The accepted methods are infrared spectroscopy or X-ray diffraction. These are quantitative methods. The qualitative method are not acceptable. Sometimes semi-quantitative methods are acceptable. We are not doing renal analysis in our hospital, so it's a referral test for us. So once we send to the referral lab, they do renal stones analysis using infrared spectroscopy. I am not very familiar with infrared spectroscopy. I got this picture from internet, and there's a if you can see there's a graph of renal stones analysis. What we get usually with the chemical composition and the percentage of the chemical composition. That's only available results to us in the report. Metabolic screening include in the blood include what we do in lab, blood urea, creatinine, the renal function, and the serum electrolyte like sodium, potassium chloride, and we measure the bicarbonate and the bone profile. We do albumin, calcium, corrected calcium. And even though ionized calcium recommended, we are not doing ionized calcium. And uric acid level we measure, and the glucose in my current hospital, what we do the fasting glucose, because we asked to come to the patient to come to the fasting, because we do spot urine test fasting. Because of that, we do the fasting blood sugar. What we did in previous hospital, we measured the HbA1c. And we also measure the PTH and vitamin D. Plasma oxalate, sometimes we do if we are suspecting patient is having primary hypoxaluria. Metabolic screening urine we do spot urine and 24-hour urine screening. Spot urine, but we do urea, sodium, potassium, calcium, phosphate, magnesium, uric acid, oxalate, and pH. Like I said earlier, we ask patient to come fast in, and there's a special SOP for spot urine sample because pH should be done within 30 minutes. So we asked to send the sample within 10 minutes in eye. So the lab staff are advised to do advised to measure the pH within 30 minutes, and the other investigation we do, and some investigation are the referral test. And patient, if we are suspected patient is having urine tract infection, we send sample for sterile urine sample for the culture and ABST. 24-hour urine sample, we ask patient to collect acidified bottle and the plain bottle. Acidified bottle, we add HCl, and we measure the creatinine, calcium, magnesium, oxalate, phosphate, citrate, and urea. And plain bottle, we measure the creatinine, pH, sodium, urate, protein, and qualitative test for cysteine. If qualitative cysteine positive, we send for the quantitative analysis. And when we measure the urate and cysteine, we add sodium hydroxide to alkaline the urine. Diet screening, the earlier what we did in a previous hospital, we went through the dietary history, and we asked the salt intake and the red meat intake and main component, and we referred dietitian to get the detailed history, and we analyzed that diet history and advise accordingly. But here what we do is we have the specialized nurse, and she asked patient to maintain 7-day dietary diary. Last 2 days of dietary diary, patients are asked to do the 24-hour urine collection. So this dietary assessment is very important to assess dietary risk factor, and it's well correlated with 24-hour urine sample, because the dietary diary maintained and the 24-hour collection are done at same time. Once we have all the detail, we should analyze all the data. What we did earlier was we went through all the clinical details and the biochemical investigation, and identify risk factors and any cause, and depending on the cause and the risk factor, we manage patient. But here we have a special software. So all the details, the urinary parameters and the dietary diary are entered to those software. Once we entered those parameters like urine volume, pH, urinary excretion of calcium, magnesium, oxalate, phosphate, citrate, and uric acid, the software is calculate the probability of the stone formation. So we can have the reliable assessment for the renal stones formation. This stone formation probability is important before the treatment, and also the assess the efficacy of treatment. Dietary analysis also, as I said earlier, we maintained a 7-day dietary diary, and all the diet are entered to the software. Once all the details are entered, it calculates protein intake, magnesium intake, calcium oxalate, and the calcium oxalate ratio, and also magnesium and purine intake, depending on the analytes, depending on the diet the patient take. And after analysis all the dietary history, the program give us the target diagram. I'm going to explain that diagram later in my presentation. If you can see here, Yeah, if you can see, my cursor is moving. The dark line is the patient with stone risk, and the dotted line is the normal population. So low volume is a risk factor for renal stone formation. Because of that, the stone formation increase with low volume, and the calcium oxalate and uric acid are the risk factors for stone formation. So because of that, high the concentration of calcium oxalate and uric acid increase the risk of stone formation. Citrate and magnesium are inhibitory factors. Because of that, it low concentration of citrate and the magnesium increase the risk of stone formation. And here you can see pH, increased pH increase the calcium stone formation. And here also some graphical presentation of risk factors of renal stones. You can clearly see if volume is decreased, all the renal stones risk increase, and the pH for the uric acid stones, low pH cause high risk of uric acid stone formation. And magnesium and citrate are inhibitory factors. Because of that, low magnesium and low citrate increase the risk of stone formation. The dark line are the increased concentration of increased concentration of oxalate, calcium and uric acid. The increased concentration increase the risk of stone formation. This is what we include urinary stones report. We have, we have the relative probability of forming stones. It's a score between 0 to 1. Less than 0.5 is safe area. It's more than 0.5 indicates significant risk, and more than 0.9 always present with the patient with recurrent stone formation. Even with we have the normal biochemical range, especially the results are in the upper normal range, we can have this abnormal probability scores. Here you can see the cutoff is 0.5, the light noted and the other scars and things are normal population. The side is the dark, the stone formers. The non-stone formers, the probability of all the these probability risk are lower than the 0.5, and the stone formers it's higher than the 0.5. I'm not sure you can clearly see this one. This is a bit crowded. This is the stone report we issue for the patient. This is the integrated report. It's include all the patient details and metabolic screen, the blood test, and 24-hour urine test plain collection, then 24-hour urine acid collection, and the daily dietary diary. I'm not sure you can clearly see they measure the calcium, animal protein, oxalate, fiber, sodium, and furin, depending on the diet we entered. And classification of patient include the risk factors, and the probability scores are there in the table, and medication history, and the after analysis all those results we add the comment what are the risk factors patients having, and the what are the improve the things improve patient should improve to prevent further recurrence. And this is the table that generated in software after analysis dietary history. By analysis all those results, we should add comment whether the patient is taking high oxalate or calcium or any risk associated with diet. this bullseye diagram is a diagrammatic presentation of urinary risk factors. This green center is the normal, the accepted level, and the risk area is the red area. The purple line is the patient line. So at a glance, we can see this patient having high oxalate excretion and the low citrate excretion. So patient, there are two risk factors, low citrate and the high oxalate. This is biochemical risk forming stone, the probability scores. You can see it's a score between 0 to 1, and the green area is the accepted area, and the red area is the high risk area. This patient is having this purple line is the patient line. So this patient is having probability risk increase in calcium phosphate and the calcium oxalate and the combined calcium oxalate phosphate stones. And this one, the diagram after analysis of diet. And the here also the purple line indicates the normal population, and the green is the normal, and the red is the high risk area. So here you can see the patient is taking high oxalate and the low calcium, and oxalate to calcium ratio is high, it is in the red area. So usually this type of patient, we ask to either cut down oxalate or increase calcium intake, because the calcium bind with oxalate and the reduce oxalate absorption in the gut. After doing all the analysis, we should manage the patient. We ask the patient to drink plenty of water, plenty of fluid, depending on their urine composition, especially if patient is having uric acidosis in stone. We ask to increase the urine, the fluid intake depending on their urine volume. We ask to maintain high urine volume by taking more fluid. And we encourage to patient to get the enough calcium, not very high calcium, the normal calcium, because the oxalate, as I said earlier, oxalate bind with the calcium and the excrete through the stool. The oxalate is the promoter for the renal stones. And we ask to reduce salt intake. Salt increase the hypercalciuria. Because of that, we ask to reduce salt intake, and the but all depend on the patient results, and the avoid excess animal proteins. Blood urea is high. We know patient are taking high animal protein, and we advise patient to cut down some animal protein and eat less sugar, because sugar load increase the urine calcium. So we ask to cut down some sugar is patient is having hypercalciuria. And this is a nice guideline for dietary and lifestyle advice. In their patient, usually patient advised to drink 2.5 to 3 liter, but it's depend on the analyte concentration and the solubility limit of the analytes. Sometimes we ask even more than 3 to 4 liters because of the concentration of the analytes. And adding fresh lemon juice to drink water, it give the citrate, and the avoid carbonate drink, and limit the sodium intake, not more than 6 gram, and unrestricted calcium intake. Here you can see urine calcium is increased when urine sodium is increased. Because of that, we asked to cut down some sodium. Patient is having hypercalciuria. Then I'm going to discuss the management with some cases which I come across during last 2 years. My first patient is 43-year-old gentleman who was referred due to recurrent renal stones, and there was no family history, and his fluid intake was roughly 1.5 to 2 liter. And there were no other significant identifiable risk factors, and blood investigation all were largely remarkable. His 24-hour urine sodium excretion 260 high at 263, and the urea excretion was high at 743, and 24-hour calcium excretion was high at 8.3 millimoles per liter, and his renal stones analyzed showed 95% of calcium oxalate. Diagnosed was calcium-based renal stones with hypercalciuria. So, as you see in my previous slide, his calcium, sodium intake and the protein intake are high because his urine sodium and the urine urea was high. So we asked to cut down salt and animal protein intake. And hypocalciuria patient, we asked to modify diet, increase the fluid intake, and cut down some salt and protein. Then we can use thiazide diuretic. What we usually do is we give the vendoflumethiazide. That thiazide diuretic reduce the calcium excretion, but some clinicians use indifamide. My second patient was 33-year-old gentleman who was referred to us due to recurrent renal stones, and there was no family history, and his fluid intake was somewhat low at 1.5 liter, and his serum calcium was high at 2.82 millimoles per liter with non-suppressed PTH of 10.1 millimoles per liter, picomoles per liter, and suggestive primary hyperparathyroidism. All other blood results were largely unremarkable, and his urine sample was borderline at 0.62, 24-hour calcium excretion 7.2, that's high normal, and 24-hour sodium excretion was high at 245 millimoles per liter, and the urea excretion was high at 593 millimoles per liter. Renal stone analysis was 100% calcium oxalate. So diagnosis of calcium-based stone with primary hyperparathyroidism was made, and this patient also had high salt and animal protein intake because his urine sodium and urine urea was high. So we advised to cut down some salt and protein intake, and we asked to increase fluid intake, and patient was referred to the endocrinology team to discuss the further management such as parathyroidectomy, and we asked for the genetic study to exclude syndrome associated with primary hyperthyroidism because patient was young. And my third patient, 68-year-old gentleman, who also referred to us due to bilateral renal stones, and there was no family history. His fluid intake was around 1 to 1.5 liter, and he was a known patient with Crohn's syndrome, had terminal ideal resection, and blood investigation were largely unremarkable. His urine oxalate creatinine ratio was continuously high at 66, and the other also we have done some repeated tests, and they all were high. And the 24-hour oxalate was high normal at 462 millimoles per liter 24 hour, and urine citrate was undetectable, and renal stones analysis was 100% calcium oxalate. And diagnosis of enteric hypoxaluria secondary to ileal resection was made. This patient also had a low fluid intake. Because of that, we asked to increase the fluid intake, and his citrate was undetectable. Because of that, we gave some supplement like lemon juice, and we start potassium citrate. And even though patient is having calcium-based stones, we prescribe pure calcium because, like I said earlier, calcium bind with oxalate and excrete through the stool. So it reduces the calcium stone oxalate absorption. So because of that, we give pure calcium. Sometimes some clinicians use calcium carbonate. In this, as this patient is having low citrate, we use calcium citrate. My fourth patient was a 71-year-old gentleman who had renal stones, and there was no family history. His fluid intake was 2 liters. Blood results were unremarkable except high uric acid at 535 micromoles per liter, and uric acid to creatinine ratio was slightly elevated. 24-hour uric acid excretion high normal at 5 millimoles per 24 hour, and renal stone analysis uric 98% uric acid. Management of this diagnosis was uric acid stone. So management of this patient, we asked patient to increase fluid intake. The uric acid stone is the one of the stones which we can manage with the medical treatment, and they maintain urine pH 6.5 to 7. And we should increase the fluid intake more than the limit of solubility. We asked to maintain urine pH between 6.5 to 7, not more than 7.5, because it can precipitate the calcium stone formation. So for this patient, we tried all those alkalization steps. First, we asked patient to use lime. Usually, we ask to 1 medium size lime or lemon 3 times per day. So, but patient was unable to maintain urine pH more than 6.5. Because of that, we start sodium bicarbonate. But even though he managed to increase his pH to in between 6.5 to 7. He was unhappy of sodium bicarbonate because he had some abdominal discomfort. So we switched to potassium citrate. Luckily, patient managed to maintain potassium pH in between 6.5 to 7 with potassium citrate. As this patient is having high slightly elevated uric acid, is the allopurinol was started, but the allopurinol is not the first line drug for uric acid stone. Usually we try to manage with the high fluid intake and the alkalization step of the urine. My next patient was the 39-year-old lady with recurrent renal stones, and there was no family history, and the fluid intake low around 1 liter, and she had the history of recurrent urinary tract infection, and her blood and urine all were unremarkable. Stone analysis showed calcium phosphate and also magnesium ammonium phosphate. So diagnosis of infective stones was made, and increased fluid intake recommended, because her fluid intake was very low very low, around 1 liter per day. And this type of stones can due to urine producing infection. So prompt treatment of urinary tract infection is very important. So we advise GP to do the urine culture whenever the patient complains symptom of urinary tract infection, and we ask for the microbiology advice for prevent recurrent urinary tract infection and treat promptly for the urinary tract infection, because it's very antibiotic is restricted in GP. So these type of patient need microbiologist advice. My sixth patient, this patient was 30-year-old lady who was known patient with cystinuria and hypothyroidism, referred to us due to identify cause for recurrent renal stones and manage patient. So urine cystine was very high, 3,719, the normal range between 45 to 150. So a stone analysis continuously, cystine calculus. So diagnosis of cystine stones due to cystinuria was made, and the cystine stones also is very amenable to the medical treatment. The maintaining urine pH in between 6.5 to 7 is very important, because like in uric acid stone, cystine also is precipitating with the low urinary pH, and also increased fluid intake, also very important managed in cystine urea patient. Her 24-hour urine cystine was 3,719. So it was higher than the solubility of cystine, that was around 1,000 to 300 micromoles per liter. The patient was advised to keep more than 3 liters of urine per day to get below this concentration. This patient was started penicillamine. And as I said earlier, the urine alkalization, we can do alkalization by giving lemon or the sodium bicarbonate or potassium citrate. That is the end of my presentation. I would like to acknowledge Dr. Marika Jordan, consultant chemical pathologist, Mid Yorkshire Hospital, NHS Trust. She was the consultant chemical pathologist in Mid Yorkshire Hospital. Now she retired recently. And Dr. Farhan Ahmed, consultant chemical pathologist, Milton Keynes University Hospital. I started renal clinic with him. And these are my references. Thank you everyone for listening, and I'm happy to take if you have any questions.
Okay. Thank you, Lanka. Thank you so much for sharing your experience with us. As you know, we are not having such separate renal stone clinics in our country. I think your information will be actually be a very useful thing for us. I hope you all have questions, or you all can discuss her experience furthermore. It is your chance to talk now.
Madam, I'm Pavitra, NHSL Registrar. I want to know the value of spot urine elements rather than 24-hour urine elements testing in this setup, as 24-hour might not be very feasible.
Yes. Yes, exactly. Thank you for asking that question. But the thing is, most of the time where the patients are not giving the 24-hour collection. My previous experience was when I did the clinic in my previous hospital, the patient are very reluctant to collect the 24-hour collection. Because of that, what we did was that we asked to do the spot urine when patient present at the clinic, and we advised to collect 24-hour urine later, because we collect the plain and acid bottle. Most of patient doesn't like to, patient don't want to collect the 24-hour collection. And also sometimes the collection is very inaccurate, even though we advise them to collect 24-hour urine correctly. We give the leaflet and we personally advise them to collect, how to collect, and we explain, and sometimes we write the notes and explain. But even with that, the collection is most of time it's the collection is inaccurate. So because of that, we do the spot urine. Some patients are not doing. But sometimes the correlation between the 24-hour and spot sample is it's very difficult to identify. Sometimes both are high, sometimes it's not high. But we measure the pH in spot sample. Because of that, we ask them to do the spot sample. that's why we do, but that's the topic is always debatable. Even my previous hospital, with we thought whether we are continue to do the spot sample, because we did 24-hour collection for the acid and plain bottle. So but the thing is, even with the hospital to hospital practice is totally different. Even though we collect 24-hour urine sample here, and my previous hospital also we collect 2 sample for the acid and plain, but I know one of our hospital, they do only 1 plain collection. They measure the calcium even without acidification. So
Yeah.
they rely on spot sample.
Yeah, that
Yeah.
24-hour and spot sample correlation has not been studied well, is it, madam?
Yes, exactly. Yeah, because they we were planning to do audit in my previous hospital, because we did both. But at a glance, sometimes there's a correlation. Sometimes there were, I know they both not correlate very well. I know
Okay, thank you, madam.
that's a topic to study. Yeah. Thank you for asking us
Yeah,
that question. Yeah,
thank you.
thank you.
Thank you very much.
Lanka, let me ask a question. Thank you for your interesting presentation. Now, what are the common drugs in UK? Like, is it like the pattern, the type of drug, the stones? Are they as in Sri Lanka? The common type.
Yes, the common type most the time I saw the calcium oxalate stone. In Sri Lanka also calcium oxalate are common, but sometimes I saw uric acid stone, and also some patient I saw with the uric acid stones, and the talking the drug, the usually the NICE not recommend to use some drug. Always asked to manage with the conservative management with the diet and the lifestyle modification. But thiazide, recently the NICE recommended to use thiazide drugs, and the sometimes even without NICE recommendation, clinicians their experience and the recent recommendations, they use other drug as well.
And I was like in this 4th and 5th cases in the treatment, this urine
Yeah.
alkalization is done by lemon and lime. I was
Yeah.
under the impression they are like acidic, the lime and the lemon.
Yes, it's citrate. It's when excreted, it's because of HIN excretion and citrate, it causes alkaline urine. With
H-ions.
the pardon.
With H-ions, the urine become alkaline.
No, HIN excretion with the citrate and the things, a mechanism cause finally, yeah.
Okay. So then the alkalize, then the treatment is to make the urine alkaline, isn't it?
Yes.
And then by giving lemon and lime, it become alkaline, the urine.
Yes. Urine become alkaline. We asked to take the because it's citrate, it contains citrate, and the mechanism.
If
Yeah.
the patient got excess citrate only, it become alkaline, no?
Yes, citrates. It's the lemon and lime contain citrate. Because of that, the citrate cause the mechanism with the HIN with the excretion of urine that cause alkaline urine.
No, the lemon itself, lime and lemon itself is, the pH is low, no? It is like acidic. But together with citrate, it become alkaline. This is what you...
No, madam, there's the lime and lemon contain citrate, because always those type of food contain citrate.
Yeah,
That's why we give.
But usually, basically, like I thought.
No, madam, I think it is because citrate urea causes some because maybe not because creating alkali. I thought some citrate has some effect of Lanka, is it due to alkalization or acidization of urine? No, citrate passing with the urine.
No, it's became because we asked to maintain the pH between 6.5 to 7. We asked to buy the pH paper and they monitor the pH. It because once I can remember exact mechanism. Once citrate excrete through the urine, it's absorb HI or something. Then because of that, urine become alkaline. The lime and lemon contain citrate. Because of that, even without citrate supplement, we asked to maintain the urine pH with lime and lemon.
Right. Okay.
Madam, she is telling that citrate binds to H plus and it causes alkaline urine.
Maybe that's the reason.
Yeah, that may be the reason. Okay, we
No,
will
Mm.
return around
Yeah.
that, Lanka. Thank you. Any more questions? Any more? Y'all have any more queries or questions to ask?
I have a small question.
Okay.
Hello,
Okay.
Dr. Lanka. I'm Dr. Shanela here. Thank you for that interesting presentation. Am I clear?
Yes,
Can
yes,
you all hear me?
yes,
Yes. Okay.
yes, Shanley, yes.
Okay. My
Yes, sir.
question is actually
Go
on
ahead.
this about basal screening for dietary risk factors for students. There you
Yeah.
said that you have a graph where you mark the amount of animal protein, purine, refined sugar consumption for which comes in grams per day and sort of like in exact amounts. So I just want to know how do you sort of calculate or measure this exact amount? Is it just rough rough calculation you take with the history, or is it something like you'll measure and take?
Yes, like I said, we have a special diary. So I should have I don't have the slide of that the diary. The special nurse is there, so she advised patient to collect all the details, what they eat and what they drink, and the medication. Everything should be documented. Exact amount of those 7 days. It's a very cumbersome procedure for patient, but to identify the dietary risk factors, that's what they recommended. Once they get all the details, they enter to the software, then it calculate the software. I'm not sure whether I'll try to show you. It's there in one of my. Can you see this slide with the dietary
Yes.
risk factor? Here you can see the animal protein. Where it's include meat, fish, poultry, and the dairy product. And the purine is component of the diet food, mainly meat, fish, poultry, and pulses such as and beans. And the oxalate is found in the most fruit, nuts, and vegetable. So some have very high level and should be avoided. This type of calculation, then after measuring all those things, they calculate the calcium oxalate and purine, everything. That is the very detailed diary. And that specialized nurse train that patient to enter everything. And after that, we get that details. We don't do anything. They enter to the software, and after that, we get the report. I show you earlier this type of report.
Okay.
Yeah, it contain. Then after seeing this one, it's contain potassium and everything is there. But that is the very detailed diary. They collect all the detail over 7 days.
Okay, so it's like you take the history and there's a specific software where you enter everything and you get these calculations.
Yes, we don't take any diet. We just ask the history. We ask just the amount of just red meat and the salt intake, but we don't go all the detail. We don't ask the specialized nurse ask patient to maintain the diary, and she collect all the details, and after that she entered, and we get this type of report. Because
Oh,
it's a
okay.
very time consuming, and we can do in the clinic because it's very time consuming and the cumbersome procedure. So it's already done for us. So we only get this type of report. I hope
Okay,
I
thank you.
answer your question.
Yeah, okay. Yeah, thank you so much.
Another thing, madam, you said that you make a score depending on the values you get by the pH, calcium, phosphate, and the values. So
Yes.
usually do the physicians use this as a guide to in their management?
Yes, because in this country, clinic, the chemical pathologists are managing renal stones. So we use these parameters when advise the patient. They because then this slide, this one, this one in this slide, can you see the
Yes,
probability risk of and at a glance we can see the patient is having the risk of calcium phosphate, the calcium oxalate stones. Then we know we should manage accordingly, because we advise patients having high oxalate diet, cut down some oxalate, and we add pure calcium, or we increase the calcium intake. If patient calcium intake is not good, then we add the pure calcium. And the patient is taking very high oxalate, we ask to cut down some calcium oxalate, but it's very difficult to cut down oxalate because all the healthy food contain oxalate, and even chocolate contain the oxalate. No one want to cut down those type of food.
And these biochemical
I-
findings also correlate with the its physical composition of the stone as well. Is it in your experience?
Yes.
Oh, okay. Thank you, madam.
Okay.
I think, are there any more? I think now it is time to end the meeting. I will invite Dr. Tushara Hewagigana, Joint Secretary CCPSL, to deliver the thanking words.
Thank you, Kisali. Let me take this opportunity to thank Dr. Kisali, to thank Dr. Lanka Liyanage, locum consultant clinical pathologist, Mid Yorkshire Hospital, NHS Trust. Thank you very much, Lanka, for that excellent presentation. And also, let me thank all the participants. I believe this is going to be our last academic event for this year, and see you soon with the new team in the Office of College of Chemical Pathologists next year. Thank you very much.
Thank you very much.